right, so I'm happy today to introduce our speaker, Dr. Fidias Leon-Sarmiento. He's a Colombian physician, obtained his PhD in clinical neuropsychology from Kagoshima University, Japan, which that you told me that's where Obai also.
I remember.
So our Obai, electrical engineering, also received his PhD there. Let's see, he did postdoctoral studies at the University of Alabama at Birmingham in neuromuscular disorders, and then later at the NIH in movement disorders and non-invasive neurostimulation. Dr. Leon-Sarmiento is currently an associate professor, Curtis E, in the Department of Electrical and Computer Engineering here at FIU, and he is chief of the multimodal intraoperative neurological monitoring unit at Baptist Hospital here in Miami. And I recently met Fidias, and so I hope that this presentation can stimulate some opportunities and discussion of collaborations and doing some research here at FIU.
Okay, good morning. Thank you so much, Doctor, for the presentation. And let's start talking about the effects of craniofacial muscle contractions on the formerly vagal nerve somatosensory potentials. So just to, just to mention the conflict of interest I have, I am the scientific advisor for this company, Blink TBI. Next, so the objective of this presentation is to present novel physiological findings that can be incorporated in the field of biomedical engineering by applying modern neurorehabilitation approaches. Next. So I'm going to talk about 4 aspects as follows. First, some basic principles of neurophysiology. Second, past concepts of the so-called vagus nerve somatosensory evoked potential, VSEP. Third, current findings on the VSEP and something that we call EVOKED. Later on, I will explain what that means. And some applications of the findings I'm going to present to you. So next. So let's start out talking about basic neurophysiology. So the somatosensory evoked potential is defined as an electrical signal generated by applying repetitive electrical stimulation about 100 to 500, depending on the pathology, depending on the body size, depending on different aspects according to each person. And the stimulation is applied to the arm or to the leg, basically. The induced signals are recorded typically over the head or over the spine. So it's working here now. Okay, so here. So maybe here, yeah. So here, so it's a typical recording stimulating the median nerve for upper limbs and the posterior tibial nerve for lower limbs. And the responses that we typically find after stimulating this nerve and recording usually over the head is something like this. So, and we sometimes use a stimulus delay for avoiding some noisy recordings, and we check the latency of the responses, measuring from the stimulus onset to the lowest deflection, and then the amplitude, the lowest peak to the highest peak. We call that the amplitude. So these concepts are important to understand what I am going to present next. So here is the typical EEG International System recording, named as 1020, because there are 10 centimeters and 20 centimeters between recordings. And over the right hemisphere, we name the recordings as, F2, F4, F6, etc. And F1, 3, 5, 7, etc. over the left hemisphere. So here is the typical distribution to pick up signals from different brain regions. Next. So that is one thing. The other thing is about cranial nerves. We typically find in the books that we have 12 cranial nerves. However, there is one more called cranial nerve 0 that is not typically studied, but is there, just to give you the information. And for this presentation, I am going to focus on the vagus nerve, which is called the 10th nerve, 10th cranial nerve. Next, please. And the vagus nerve innervates all of the body parts. So here is just a summary that the vagus nerve innervates the heart, the spinal cord, the kidneys, and also the ear. And especially in the ear, we find that the vagus nerve goes to this region. Next, please. Name it as the traversal. This region is the only one region innervated by the vagus nerve as a sensory branch. The sensory branch of the vagus nerve comes from here and goes to the brain. So this is a normal earlobe, and using this approach, using this advantage, this group from Germany about 20 years ago stimulated the tragus nerve, the tragus region, using a device like this, non-invasively, and they presented these responses that they found over the scalp. So here, for example, is the left hemisphere, the right hemisphere, the left and the right. And they stated that this is the vagus nerve evoked potential. And if you see here, this is the latency, the over the horizontal, and the amplitude is over the vertical. And in the horizontal, you will see that if this is 10 milliseconds of duration, we have here 1, 2, 3, about between 2 and 3 milliseconds, and the duration goes up to 2, 4, 6 milliseconds, 5, 6 milliseconds. So going back to this slide, so this is what the authors presented about 20 years ago. A response of about 2 to 6 milliseconds of duration, and the amplitude of about 600 microvolts or so. So next, and then these authors and other groups presented information about that response and went further, saying that this response could differentiate between, for example, Alzheimer's disease and major depression patients. So they presented these findings and other findings. So they studied Parkinson's disease, other types of dementia, and so about 20 years of research doing these studies. Next. So we wanted to replicate the study, the initial study, and also wanted to replicate not only in healthy people, but also in patients. So, but when we reviewed the literature, we found something like this. This is something that I want to make our students today, for example. What could be interpreted from these findings? That there were no specific places to record the responses. So it was very erratic, the way that, every paper picked up signals at different places, and making, things like this is almost impossible to replicate findings, because it means that, there were no specific places to record the responses. However, we went to healthy people. Then after this, we checked all of the reports and publications, and found, these were the data collected. So the latency for what they call, let's go back, please. Let's go back, please. So, okay. So you see here that this potential was named as with different conventions. So P1, N1, and P2. Positive 1, negative 1, and positive 2. Let's next, please. So, and they measure the latencies and the amplitudes and the interpeak latencies, and these were the values they found. So about 1, 2, and up to 4 milliseconds of the P2 latency, which was a little bit, long for typical evoked potential, but we accepted, you know, at face value, we accepted the data reported. Next, please. So we went, you know, to the operating room and studied some people that were, you know, for surgery for different purposes, not for brain surgery or any other supraspinal surgery. And we tried to replicate the findings. However, we couldn't, because we put the delay, here is the delay, and we started finding something different to what was published. So what people had published here, P1, N1, and P2, is this response. But what we found was an earliest response to the findings typically published. And when we measured these responses, so we found that they had about 790 nanoseconds, which was much faster than the responses already published. So at the beginning, we considered that maybe this was an artifact, maybe. And we played different ways. We tested a lot of people, healthy people, and we consistently found this response. Here, you see that this response here increases along with the increase in the stimulus intensity. This was 2 milliamperes of stimulation, 4 milliamperes, 6, 8, and 10 milliamperes of electrical stimulation. So we call this as B1, B2, and B3. B for VAGAL, 1, 2, 3 for the different peaks and latencies that we measure. Next, please. So maybe we were wrong, we say, and we wanted to review the papers published in patients, from patients, different disorders, Alzheimer's, Parkinson's, dementia, depression, schizophrenia, and so on. But our surprise was to find that the same group, the same people did it in a different way, the approach to study the same response. So that was something strange for us, to say something. But the lesson here is to ask people for future generations doing research to be consistent with the way of doing the research that we are doing, because otherwise it will be impossible to replicate anything we found. So in this case, we found that in patients with different neurological disorders, authors used another approach, another way of recording the signals. However, what we found was something like this in the latencies of the responses, named by them as vagus nerve somatosensory evoked potentials, meaning that it was totally, you know, erratic, uneven, and without any significance. So next, please. So we wanted to see what happened with in patients with some neurological disorders. So we tested, in this case, a patient who had a low-grade glioma at the left temporal lobe. And we carefully placed the electrodes, and we found again the same finding. So this is the earliest response that we found. So let's go back, please. Another one. And that's why we say that this is the earliest vagus evoked response by stimulating tragus. And that's why we call this Everest. Okay, so next, please. Okay, so we replicate our findings in patients with this low-grade glioma. And next, please. So we went back to the literature to found something called as the vagus nerve evoked potential, was this type of recordings that look like what we found as the latest part of our responses, not the earliest part. Now, you see here that if this is the horizontal time for the latencies, so we see here that it goes from 0 to 6 milliseconds. And typically the response that these authors found was at around 1.5 to milliseconds. What we found was around 700 nanoseconds. Next. So we trying to understand what we found. We arrived to this concept, and this is a concept that we have in neurophysiology about volume conduction. And volume conduction is a phenomenon that appears when the polarization and repolarization passes beyond the point of signal recording, spreading currents throughout a volume. In this case, for example, this is just an example, stimulating here the ulnar nerve and recording at different points of this hand. So we found responses like this, but also the current spreading out in different ways like this. And this is the so-called volume conduction, that if we don't care about this, we end measuring these responses like true responses, but it's just an artifact. So, and according to neurophysics rules, the volume conduction is a three-dimensional version of the Ohm's law. So the action potential increases with the stimulus intensity and decreases with both radial distance and conductivity. Next, please. So now I arrived to the point of this conference. So if we found those findings discussed before, so the next logical question is, if that response, let's go back, please. Let's go. Okay. If we are saying that this is not a true response, but this is the true response, and if we say that this is a volume conduction response due to some kind of current spreading around the muscles that we have in our skull. So next, please. The logical question was, okay, if that is an artifact due to muscle activity, let's do the muscle contractions to see how these two different responses behave. So we study 5 healthy participants, and we stimulate at 2, 4, 6, 8, and 10 milliamperes. We recorded in the same way, and we did different maneuvers. We tested subjects while they had the eyes open, the eyes closed, and we did several muscle efforts using the auricular-oculi muscles and the mandibular muscles, the masseter muscle, and so on. So next, please. And these are some typical responses that we found. This is the earliest response that we found after stimulating the tragus. And this is the volume conduction that we discovered that was published as the vagus nerve somatosensory EVOKED potential. And these responses were obtained after stimulating at 2, 4, 6, 8, and 10 milliamperes over the tragus region. Next, please. So here is another dramatic example when we do masseter muscle contraction. So in these two cases, at different muscle effort levels, so we found something like this, you know, and the initial response that we found still remaining. So we submit this paper, is now approved for publication in our report. Next, please. So this is another example on what is happening when we do this study using the tragus stimulation. And this is a T4, meaning this is over the right hemisphere temporal region. And this is the EMG activity while one of the subjects had the eyes open, and when they did a muscle contraction. So in this case, so this is the receiver has this eyes closed. I'm sorry, the eyes closed. So the point is that even during relaxed times and having the eyes closed, we still see activity over this EEG region. So something like this. And then when we asked the subject to do an actual muscle contraction, we found much more activity over the temporal region, meaning that so when we studied these responses, we found actual responses and also muscle activity around that. So next, please. So this is the summary of the amplitude and the duration of the responses that we found at different muscle activity levels. This is with eyes open, eyes closed, auricular-oculi with 50% of muscle effort, 100%, and the masseter at 50 and 100% muscle effort. So this is the amplitude and this is the duration. We found, using different statistical analysis, that the masseter activity was the hardest activity that induced, a differential information around the EEG electrodes placed over the skull when we stimulate the tragus region. Next, please. So, interestingly enough, we found recently, it was published last year in scientific reports, in animals, something similar to what we found in humans. So they stimulated, these authors stimulated the tragus region with electrical stimulation, different levels, for example, like this. Here they increased the electrical stimulation, and they found that at the beginning, the initial responses that were very close to the zero line, meaning that is very, very, very close to what we found. So this is a typical response that we called the Everest. And they demonstrated that it was due to A nerve fiber activity. Next to that, there was another activity that was due to beta fibers, to B fibers, I'm sorry. And then all of this activity was due to C fiber stimulation. And they typically found that it was due to muscle activity. So it demonstrated and supported our findings that what we found was a true response due to A fiber stimulation activity following tragus nerve stimulation using electrical stimulation, as we already showed. So next, please. So then we found that people is finding now new pathways that is signal, in this case, for example, mechanical pain from human skin to the brain, and also from the thalamus, so to different brain regions. And authors are calling this like hyper direct pathway or ultra fast systems, meaning that these are responses that are still in the infancy, let's say, because we typically studied very late responses, but these responses have around, let's say, 500, 600 kilometers per hour of velocity, whereas the rest of the activity is around 100 kilometers per hour of velocity. So meaning that, what we are finding are new things that go very fast to the brain, and we are still, again, in the infancy of knowing what is going on with these responses. Next. Is there a place for biomedical engineering for studying this? The answer is yes. Yes, there are people around the world who are studying the auricular vagus nerve stimulation using different engineering perspectives. Next, please. So, typically, what people do is stimulate the tragus region using devices like this in outpatient settings. But still so, they are finding, that stimulating the tragus here is very nice it's a very promising tool to improve, for example, epilepsies, stroke, or heart problems, like, for example, atrial fibrillation. So this is the way that people is approaching now from the biomedical engineering point of view. Next. Oh, so I hope you find. So, but what happened in the operative in the surgical room when patients come with different problems and we don't know what's going on with the autonomic system, because the vagus nerve is the parasympathetic pathway that we use to defend our bodies from different attacks. So here we are studying now how the Everest here, I hope you see, so here is distributed in the different brain regions to find what is the best place that we could pick up the signals. So we are studying now that. So it seems that there are some, you could see here, that some let's say C4, C6, C6, T4, but still we are, studying what is the best distribution and mapping, within the brain, these new response because, unfortunately, so if you see here, this is a typical volume conduction. So this is 2, 4, 6, 8, 10, 11, 12, 14, 16. And you see how the first part of the responses remained. But after that, you see here how this volume conduction increases along with the electrical stimulation, but the wave is totally, different to what we define it as somatosensory evoked potential. Next, please. This is another interesting case that we found recently in a patient who had a right frontotemporal tumor. And you see here that in this specific area, the response was gone, disappeared. So it called our attention and we went further next. And we had now, not a lot of patients, but about 40 patients tested for this specific pathway. And this is just an example of that. So this is a patient who had also a temporal tumor. But you see here, for example, that we could pick up the signals in these areas, but here, before the tumor was removed, the responses disappeared. But after the tumor was removed, immediately the response came up. So it was very interesting to see that this is a very plastic region that changed immediately. The tumor was removed. So, and interestingly enough, we are trying to follow these patients according to the blood pressure, heart rate, and so on, because there is a correlation between the activity we found around these areas and the sympathetic and parasympathetic measures. So that is a very interesting situation that we are finding now, and we are still studying, more and more about this new response. You see here again that when we increase the stimulus intensity, you see this is what we call it the volume conduction. This is the muscle activity already discussed, and the earliest response or the Everest is around here, very consistent. Next one. So what is the role of biomedical engineering? For example, this is just one example. So what we are using now is custom-built electrodes. So something like this. So we are working now with the faculties from the University of Florida, trying to develop a new electrode to be used in the operating room, because there is no electrode to be used during surgical procedures, and that is a gap that we found, and could be an interesting study to be developed maybe here with somebody here interested in doing research around this, because what people developed was the electrode for studying outpatients, but not in patients out of the surgical room. Well, we are interested now in studying these responses under anesthesia while the patient is operated for different type of tumors, but we haven't gotten the actual electrode that could be used, in every single surgery. So that's why, we are, in the need of finding students or biomedical engineering that could be interested in studying something more about this. Next, please. Questions? We have still a lot of questions because we don't know the distribution of the response in the brain. We don't know what is the relationship with the actual autonomic function, but we are finding some interesting results that hope to be published soon. But questions are there that so we have still room to to develop a program, a new line of research around this, specifically for people going to the surgical room, having neurological problems, and to understand what is going on with the physiology around these new pathways that have been discovered. Next. In conclusion, we could say 100% that we are sure 100% that the formerly vagus nerve somatosensory evoke potential is an electromyographic activity that could be triggered by subtle, mild, and strong craniofacial muscle contractions. So it means that this response, published during almost 20 years, is by no means the signal expression of the stimulation of the tragus sensory afferent pathways. So it's not an actual autonomic evoke potential. On the other hand, the evidence that we found at the nanosecond magnitude can be a novel tool to monitor parasympathetic function regulated by auricular neuromodulation in health and disease. Next, please. Thank you. So to you, to the university, to Dr. McCollum, and to the Neuro Miami group that we are working now with them. Thank you.
All right. Thank you very much. Great presentation. So I have a question. My first question is, did you show a picture of the anatomy of the relationship between what do you call this little thing and the vagus nerve? Did you show that anatomy?
Yeah.
Okay. So my question is, are there any animal models that have a comparable enough anatomy to be able to do this type of study and look at, in an animal model?
Yeah, sure, absolutely.
An animal model.
Absolutely, yes. So the paper that I show you published in scientific reports was actually done in animals. And
you probably said that, and I just
yeah. So rats and mice, are now studied using this approach because it's very promising the way of stimulating the tragus, because it's the only let's say non-invasive vagus nerve place that could be used to modulate all of the autonomic system. Before this technique, patients typically had to be operated over the neck and to be implanted with some devices, and that had some kind of morbidity and mortality and so on. But now having this discovery that tragus is a pure sensory vagus nerve stimulation place has triggered a lot of publications. The importance that I think we have with these findings is to be able to monitor what is going on with the therapy before and after, for example, what is happening within the brain, because until now, so patients typically are stimulated over the tragus and follow up about, let's say, different, EEG or so, but not as specific as this response we found, So this response open a new field of testing, of monitoring, the actual pathway, in a very reliable way, as I show, with patients having tumors, brain tumors or so. So meaning I didn't want to go further than that, but it seems that there is a brain area, a specific brain area that controls this response, very specific. And that could be called, let's say, like a pacemaker or so, So we are trying to find that. Actually, we got some interesting findings from some specific brain areas that correlated with, for example, difficult control blood pressure, and patients having, let's say, hemorrhage after surgery, because they were touched in that specific area, and it was very difficult to control by regular or typical pharmacological measures. So meaning that maybe like the visual area, like like any other neural area, we are very close to find a very specific brain area that controls the parasympathetic system. That's the point.
I want to invite those in the ether to ask questions in the Q&A or the chat box, and we'll monitor that. So if you have any questions, please please type those in.
So my question is, if this is what is you refer as a sensory component of the vagus network, I would believe that would be classified within the non-autonomic component of that network. How do you know that stimulating that particular pathway will have an output into the non-autonomic branch?
Non-autonomic. Non-autonomic.
Yeah. Well, how do you know that stimulating this
Network.
non-autonomic component of the vagus network will create a response in the autonomic branches, the parasympathetic branch of the system? Because my assumption is this first stimulation goes to some sensory area. So it's an afferent pathway within the non-autonomic. So why does the normal vagus stimulation happen in the
cervical branch,
cervical branches, which is targeting that parasympathetic?
Exactly, the efferent pathway.
Exactly. But how do you know that these will go back to the?
Because there were studies showing the effects of tragus stimulation over the heart, for example.
So behavioral stuff.
In animals, over the gut. So, for example, and different approaches were done that demonstrated that it goes directly over those regions. That's why, for example, I used in these studies just I went just up to 10 milliamperes, because it was found that is the safest stimulation for humans without, let's say, down-regulated the heart function, for example. It's safe for everybody. Beyond that is a little bit risky. So and we don't know yet. So how far can we go beyond that? So that's why, for example,
So another question related: if these two early components, the areas, are actually the fiber component and not actual body conduction effect, wouldn't that peak depend on the diameter of the myelinated A and B fiber that because this is, I mean, I will assume this is a fiber that conducted 20 meters per second or something like that.
More than that.
No, they have to be very large or myelinated.
It's a very good question.
So
very good
if there's
question.
any characterization of that fiber,
very good question. Yeah, exactly. Because typically, when we teach physiology, anatomy, and any other neuroscience course, so we typically teach students that we have A beta, A delta, C fibers, and sometimes B fibers. So we start from A beta fibers, but the fibers involved with the Everest belong to the A alpha fibers, which are the fastest fibers we have, and they conduct at around 150 meters per second. So which is too fast. It's around 500, 600 kilometers per hour. So, and that makes sense, because to react, when we as humans or maybe animals, to react to any outside influence, so should be fast. We cannot wait 2-3 milliseconds to see if we can respond to that enemy. For example, let's say in animal, 2 milliseconds in the brain is too much, or 4 or 6 milliseconds, as sometimes the previous paper showed. 6 milliseconds is too much to react, and that makes sense to me, because if we could react at 600 kilometers per hour, let's say about 350 miles per hour, something like that, 400 miles per hour. So makes sense, because it's something fast, so and that's
what is the diameter of these A and B?
Oh,
is this myelinated or is
it's myelinated. It's very the more myelinated fibers. The bigger, the wider. The point is you could find, and you and I could share with you some papers that people studying the components of the vagus nerve, for example. They have published at different occasions that, okay, the afferents are composed by A beta, delta, C, and so on. And we found some thicker fibers that are not of our interest, something like that, And we found, typically in several pathological papers showing the big diameter of the fibers, but they don't care. They don't care because we have been taught that we just be concentrated on A beta, delta, or C. But we have forgotten the A alpha component that is now not only for this. So other people are studying, fastest pathways in the human brain are finding, for example, that the trigeminal nerve also has that component, the sural nerve. It seems that we have another kind of, neural system still, not understood, but we are there, we are working there, but the field is open, it's open, and we are now working in the development of a new device for being used in the operating room to study this, in patients, going for different type of subjects.
There is, just to let you know, there is a 44-person in the talk, and there is a question.
Oh no, that's just a comment that was answered. There's no
Okay.
question.
Okay.
So another question. You had, towards the end, you had implied or said that some unanswered questions. Can you give us an idea of some other avenues of investigation that this work opens up?
Yeah.
That hasn't been looked at.
For example, so we want to study implants or the tragus region to modulate epilepsy. That is something that should be understood because so typically epilepsy, is seen as a let's say a very widespread disorder. However, if we could find a pacemaker like this to control, the problem, is a very, very big, avenue to be followed up. Another way to approach this that we want to is having today the possibility of going to the operating room in my case. So we want to study, those areas that could be maybe internally modulating the response. And so in a similar way, like people is doing now, for example, applications for Parkinson's disease, for modulating the tremor in Parkinson's disease, applying devices within the brain. We are thinking and planning, to have something like that directly over the brain area that seems to control all of these things,
But there is already Somatronic and Europeics have already FDA system for this subcranial or subcortical stimulation. And they have been very successful. Here we have,
Right.
we have a lot of patients already planted. So in order to go in that direction and recruit, because this is less invasive, it's more less invasive in general. So in order to get the attention to people that move in that direction, I would say you will need to demonstrate with a lot of patients that you have
absolutely.
actually impact.
Absolutely. Yeah. So there are many
What
ways.
about stroke and brain injury? Any applications there?
That's a huge field to be studied. And the point is that so we still need to know, for example, about the repetitive stimulation to control the autonomic system. That is something that we don't know. The brain area that we are studying now. the frequency, the duration of the stimulus, all of those things should be still, studied. So stroke is a big area, and it not only stroke, but what I have seen during years is that patients with a stroke many times develop heart problems. And people believe that the problem came from the heart to the brain and not in the opposite way. So if we could manipulate the brain problem, hopefully we could improve the heart problem as well, not in the opposite way, something like that. Is the way that we are thinking now. But the first project that we want to finish is to construct a new device that could be used in the operating room. That is our first focus now.
Now, why is something implemented in the operating room, except for the sterility issue? Why is that more of a challenging than an outpatient? Out of the not necessarily outpatient, but why is that more challenging?
Because the amount of information, electricity, the bed, the cables, all of those lines around the patient make a lot of noise. Make a lot of noise, and that's why we cannot use the same, devices. So it's totally different. Plus the fact that should be sterile.
That seems really
so could be, so we cannot, insert something in the ear of a patient and then, it has ups and downs. But the main point is the noisy environment that we have. So that cannot be, it's not friendly to pick up signals, easily. So I show you the figure, but to get that figure, you could imagine. So we worked around for almost 2 years, to get, to get the signals, because it was not easy, to find the right place, the right cable, how can we avoid, inserting more noise to the signal, something like that, So, but is there?
So if there are no questions from our online audience, I want to thank our speaker. Appreciate you.
Thank you so much, Doctor.